structure, sits in the chest, kind of at an angle, second intercostal space down to second rib, second intercostal space, depending on the textbook, down to about the fifth rib and the fifth intercostal space. Most of it sits on that other side, the left side of the sternum, probably about 2/3. So we got 2 chambers on the top, the atria, 2 chambers on the bottom are the ventricles. The ventricles are the pumps. So when we get into the cardiac physiology, you're going to see that those atria do contract, okay, but they're not considered pumps. We're talking about things that move things out to other parts of the body. Really, the atria is simple processes to take the blood that remains in them at the end of a particular phase of cardiac physiology and puts it down into the ventricle. So the ventricles have all the blood they're able to pump forward. Because of that, we have this one-way valve structure, okay? So between the atria and the ventricles, we have atrioventricular valves. Tricuspid on the right, bicuspid on the left. The other name for it, again, besides the bicuspid is mitral. The name actually comes from the fact that a bicuspid valve looks similar to a bishop's hat. It comes to a mitre. That's where the term comes from. And this is probably the one that's used clinically. Again, you should know bicuspid though, because it's still used from an anatomical standpoint. They are attached to these things called the chordae tendinei, which are attached to papillary muscles. Okay, the papillary muscles are in the ventricle. I'll talk about how they work today. We talked about some of the structures that existed in fetal circulation that have remnants in adult circulation. So we have this connection up here, the PFO, the pachypharyngeal valley, and then we have a connection, if I can find that better, right here, which is the patent ductus arteriosus. So this is eventually going to get sealed off and become the fossa ovalis. That's the structure in the adult. And this is going to lock itself off and become the ligamentum arteriosus. Okay. Talked about the great vessels. Those are the ones that are attached directly to the heart. So we have the superior vena cava, which brings blood back to the right atrium. We have the inferior vena cava, which brings blood back to the right atrium. There are no valves that are present there. We have the pulmonary trunk. The pulmonary trunk is going to give rise to pulmonary arteries. They come off of the right ventricle, right here. So the pulmonary arteries are going to go right there. That ligamentum arteriosum. Ligamentum arteriosus is also another term you could use. And then we have the pulmonary veins, which are bringing blood back to the left atrium from the lungs, being oxygenated. And then we have the aorta, which goes off to the rest of the body. So those are the great vessels. Okay, the pulmonary arteries and the aorta have valves in them. They have semilunar valves. All right. So I'm just going to briefly talk about how these two things work slightly. They work differently, but in the same goal, which is to prevent forward movement of blood. So with the atrioventricular valves, we have blood that's going to be coming down. And again, I told you that these valves are open most of the time. Okay, so the blood actually is being returned into the right atrium and left atrium. Basically, it just falls into the right atrium and goes immediately down into the ventricle because there's no floor in that chamber. It's closed or open most of the time. When there becomes a greater pressure in the ventricles, then these valves will close. Okay? Now, the point of the chordae tendinei and the papillary muscles is so that when the ventricles contract, the valves don't push open into the atrium, because that would be wrong, because that's not forward movement of blood. So right before the ventricles contract, because they're one of the pumps to push blood forward, the papillary muscles exert a slight contraction. So we're talking milliseconds, slightly before ventricular contraction, and they pull them down just enough, like an anchor, to prevent them from moving up into the ventricles. Not pulling hard enough that they open back up again, but pulling down so that they can oppose the pressure and they won't flap open into the chambers above. Okay, because remember, when blood goes in the backward direction, we call it regurgitation. And then the regurgitation is named for the incompetent valve. So if it was to happen here in the right atrium, and the tricuspid valve would be tricuspid regurgitation. Now, obviously the same thing is going to be happening in the left atrium and the left ventricle. Okay? The semilunar valves, slightly different. These are actually pushed open. So as the right ventricle into the pulmonary artery and the left ventricle into the aorta contract, they push the valves up and open. So any blood that doesn't make its way around the pulmonary artery or around the aorta comes back. And I don't want backward flowing blood. So in this instance, these act like little cups. So once they get pushed open so blood goes through, they come back together and blood comes down and hits the cups themselves. You can actually see this on when we monitor patients from a hemodynamic standpoint. When we put catheters in patients' arteries and patients' veins and then hook them up and transduce them, so hook them up to the monitor, we can see that pressure as it comes back and hits. It's referred to as a dichrotic notch, and we'll all show you a picture of it when we get to the actual cardiac physiology component. But that's how the valves function. So you can see a difference between the atrioventricular valves and the semilunar valves. Any questions on that kind of anatomy so far? Okay. So we ended up with these circulations. Okay. There are three circulations that we talk about from a cardiac standpoint. The first one is our pulmonary circulation. Now, one of the primary goals is that you're going to have blood being sent to the lungs to pick up oxygen. And again, even though I've written it here, and I just want, because that's what the book says, I want to make sure people are using different terms. So oxygen, what the book calls oxygen poor blood, I want you to be referring to deoxygenated blood. Okay? Oxygen-rich blood, I want you to refer to as oxygenated blood. That's the more correct term. Now, the pulmonary circulation is not very far from the ventricle. So here is the right ventricle. Here's my pulmonary trunk, pulmonary arteries. Again, you have two of them. One goes to the right one, the other goes to the left one. And they don't go far. So the right ventricle, and be about right there, is going to push the blood out through the pulmonary trunk into the pulmonary arteries. They're going to go to the lungs where they're going to pick up oxygen. That's their whole point. They're also going to get rid of carbon dioxide. Because as they come here, and we'll talk a lot about this physiology when we get into ANP3, the carbon dioxide will stay here, and then we will exhale, and that gets rid of the carbon dioxide. When we inhale, we obviously bring in the oxygen. So this distance is not very far. Okay? Now, when we talk about vascular physiology, and we're going to get a little bit more into it after I, tackle all of the cardiac physiology. It's basically just physics, because we're going to learn a lot, or go back over a lot of this in respiratory physiology, because the only difference is we're talking about air moving through a tube in respiratory physiology. Here we're talking about blood moving through a tube. So we look at, you don't have to write this down, flow is equal to the delta P divided by resistance. So we will spend a lot of time with this equation in vascular physiology. You're not going to have to do, this is a chapter, by the way, that you will have to do some math, but it's easy math that you shouldn't need a calculator. And I'll be saying this as we move through here. You cannot use your phone for obvious reasons as your calculator. So if you think that you're not doing very good with math, okay, and really all the most math it's going to be is addition, subtraction, multiplication, and division. And I'm not kidding. hearing about decimal points, you should be able to do it in your head. But if you think you need a calculator, you need to bring a calculator. Your phone is not going to be allowed. Okay? But when we look at this equation, if you're not too comfortable with math, all right, then one of the things that you can do is just plug in fake numbers. This is a physiology class, it's not the lab. If we were doing this in lab, then you would have to use specific numbers. But, you know, if I want to figure out how these things affect this stuff over here, plug in numbers, 1 over 1. So if my delta P was 1 and my resistance was 1, my flow would be what? 1. Now, let's say that my resistance goes up. Okay? What's a bigger number than 1? 2. What's that number? 0.5. So what happens to flow when my resistance goes up? It goes down. Okay, you don't even really have to plug numbers in. The more you get used to just the overall setup, anytime the bottom number goes up, this number goes down. Anytime this number goes up, this number goes up. Simple relationship. That's all we're working for in class. Again, if this was a lab at the University of Oregon and we're going to be plugging in real numbers, it'd be totally different. But here I just want you to understand the relationship. Okay? Now, so flow resistance obviously affects flow of things moving through, correct? So, what are some of the things that affect resistance? Well, first, we have viscosity. What the material, how thick the material is inside that tube. So the thicker the material, the increase in resistance. Okay? Diameter. How far across is it? The greater the diameter, the less resistance. The smaller diameter, and that should make sense. We've all, you know, had a milkshake with a milkshake straw, milkshake straw, and you know, if you were to try and drink the milkshake with the little coffee stirrer straw, it'd be harder to do, wouldn't it? Why? Smaller diameter, increased resistance. Okay? And the last one is the length. The longer the length, the greater the resistance. The shorter the length, the smaller the resistance. Now, going from the right ventricle to the pulmonary arteries, or to the pulmonary arteries to the lung, long distance or short distance? Short, therefore less resistance. Remember this picture where we talked about cardiac muscle? And we showed you somewhere in here? No, I didn't. Lots of pictures in this chapter. So, the wall. Remember, this is a cardiac muscle. Works very similar to the skeletal muscle. The increased work is going to cause an increase in the muscle mass. This does not have to work very hard. Why? The system that it pumps into is a low resistance, so not a lot of work. So the wall is very small. So it's going to push blood pump blood into the lungs, pick up oxygen. The blood's then going to come back through the pulmonary veins. Remember, there are 4 of them, 2 from each side, and all 4 of them will empty into the left atrium. That's the pulmonary circulation. The second circulation is systemic circulation, meaning pumping blood to the rest of the body. That's what the left ventricle does. So I picked up oxygen, I've gotten rid of carbon dioxide, now I'm going to take oxygenated blood to the tissue. So remember, that was the whole point of blood. And our vascular system was so that I can deliver oxygen to the tissue, so when I make ATP, I get more bang for my buck. Remember, when we don't do it with oxygen, I only get 2 to 4 moles of ATP for every mole of glucose. But when I do it in the presence of oxygen, I get 32 to 36 moles of ATP. So, more bang for my buck. much, much, much longer system. So increased length, increased resistance. Increased resistance means more work. That's the reason why that ventricle looks like it does. Now, this picture is slightly misleading because it makes it just look like they're all set there. The orientation of muscle looks like this. When you look at the bottom of it, actually, it's referred to as the vortex, because its whole point is I'm going to empty the blood in my atria down into the ventricles, and then the ventricles are going to push. So there's two analogies. One of them most of you have used. One of them some of you have used, or at least have seen. I've only seen one of them and done the other. So if you've ever had to wring out a dish rag, you're cleaning it up, or a sponge, you kind of squeeze the top part, then you squeeze the bottom part. Because if you squeeze both sides, then it tends to make the things move all over the place. That's the same way this works. The other one is milking a cow. You know, milk the cow, but what I've been told is you kind of start at the top, and you squeeze, and then you bring your hands down. Same process. So we're in milliseconds. This is squeezing. It's pushing blood into the ventricles, and then the ventricles, being the two biological pumps, are going to squeeze and shoot blood out the sides. The sides being the pulmonary artery and the aorta. And that's going to occur, the systemic circulation is going to move all the way through until blood comes back to the right atrium. So here's my aorta. This is going to the rest of the body. It comes back to the superior vena cava, the inferior vena cava. And then that's the end of the systemic circulation. Now, when we look at this heart, even though these chambers are filled with blood, okay, and remember, the heart needs a continuous amount of blood. It doesn't stop beating when we go to bed at night. It doesn't stop beating when we sit down in our lounge chair and watch the news or watch what have you when you're not using your legs. I mean, our legs are still going to be using oxygen, but not to the same degree when you're up walking around, you go running, you go biking, what have you. So this muscle needs to have oxygen. It does not derive its oxygen from the blood on the inside of the chamber. Okay? So there has to be another way to get blood to the muscular tissue of the heart. And it does it via the coronary circulation. These are vessels that are on the surface of the heart that are delivering oxygen to all the regions of the heart that need to be nourished, so to speak. And then it diffuses down. Okay? And I'll talk about this again in a minute, but for people that have bypass surgery, okay, it's called coronary artery bypass graft. Again, we're very lazy in the medical field. We call them cabbage. The patient's having a cabbage. That's what we're referring to. These are the vessels that are being bypassed because they're occluded at some point. So we're going to put other vessels in their place to bring an increased amount of oxygen and blood to that area. Okay? Now keep in mind, well, I'll go back and talk about that in a second. So when you look at them, again, what you're going to see here is the lighter colors are the ones that are on the posterior side, and the darker red are the ones that are on the anterior side. You don't have to know every vessel on there. I'm going to go through the vessels that I want you to be familiar with. The first set of vessels are called the cardiac or the coronary vessels, okay? And you have two of them. You've got the left coronary artery here, and you have the right coronary artery there. Now, again, you notice that they're darker color, which means they're in the background. So they come off of the aorta. other words, they get the freshest blood in the body, because as soon as blood comes out of the left ventricle and gets sent to the rest of the body with every contraction, the first vessels off of that aorta are going to be your coronary arteries. Now, your book is going to spend a little time talking about the fact that there is a different setup for this process. So some people have a different orientation. Some people, it's the left coronary artery that feeds the whole entire heart. So the one I'm teaching you is the average, okay? But if you happen to graduate, become an RN, and work on a cardiac floor, and you read through the H&Ps of your patients, you might see the cardiologist and cardiovascular surgeon saying that the patient has, this type of circulation to the heart. But this is the average one I'm going to be going over. So this left coronary artery that comes off is going to split. The first one is going to go, it's referred to as the circumflex, and it goes around to the base or the posterior side of the heart. You can kind of see it wrap around. The second one continues down, and it's referred to, I'm going to give you actually three names for it. One is referred to as the anterior interventricular artery. By the way, this fits in a sulcus, so there are some structures to be able to delineate. This is a quick side note, where structures are from surface anatomy. So here we have this interventricular sulcus coming down, and so this is the anterior interventricular artery. So this little line of fact is a delineation between the left ventricle and the right ventricle. So if you're somebody who does a lot of cooking and you cut up chicken, or if you ever watched a video on cutting up a chicken, there's little fat marks on chicken that also help you make this delineation between certain parts of the chicken. Okay? It's kind of like nature's way of saying, right here, this is going to give you 8 pieces from the big giant prior. So, and we also have this group right here, which is called the coronary sulcus, or the atrioventricular sulcus, and that's the distinction between the atria and the ventricles. So again, just a little X marks the spot on the surface of the heart type of a thing. Let's go back to the circulation. Now, the more clinical name for this is called the left anterior descending artery, the LAD. And again, we get very lazy, so sometimes when you read op reports from a patient that had coronary artery bypass graft, you'll see somebody, they might say they had a Lima lat. And that's exactly how it's written. Lima, arrow, lat. And it stands for the left internal mammillary artery to the left anterior descending. So it's just some and I'm not going to get quizzed on that, but if you happen to be working in the hospital now and you read through someone's H&P, you might see that. So this feeds the left ventricle. The left ventricle is the biggest pump. Why? Because it pumps blood to the rest of the body. So if you were to have an occlusion in this vessel, say right here, then anything distal to that occlusion would not be getting any blood. Okay? I've talked about this with strokes. I've talked about it with just blood flow in general. But anytime I'm not getting blood to a certain area, it's called ischemia. Now remember, we talked about the fact that I can actually not be hypoxic, which is a low tissue level of oxygen, even though I'm decreasing my blood flow, because I can increase the amount of blood going to the area. My heart can beat faster. Okay? But ischemia just means I have a decrease in blood flow. Now, if I had a clot here, I'm going to have ischemia first, and if we don't fix that clot, I don't open up the blood flow, I'm going to injure the tissue. Now, injured tissue has the potential of repairing itself. Now, if this process goes on, I have an infarction. Infarction is tissue death. Remember back to histology, there's some tissue that does not come back after infarction. Cardiac tissue is one of them. Central nervous system tissue is another one. It doesn't repair itself. So, if you've ever heard of somebody having a myocardial infarction, that's a heart attack. Massive coronary, heart attack. Heart attack. All different words meaning the same thing. The patient has tissue death. So the third name for this, because this goes to the big pump that pumps blood to the rest of the body, is referred to as the widowmaker. So if you watch any of the Bear aspirin commercials that are on TV, they're talking and it's like, yeah, the cardiologist came out and said, I beat the widowmaker. They're referring to the fact that the person had a clot or an obstruction in this vessel. And they were still able to get in there, get that clot going before the patient had an infarction. Now, that right coronary artery is going to give rise, it's going to come off here. And the only one I really want you to know from that standpoint that has a name is called the right marginal artery. And this has a tendency to feed or supply the right ventricle. Now, one of the branches of the right coronary artery is to go to the back, as you can see, and they're going to meet up. Okay? When blood vessels do this, where two arteries are going to come together, it's referred to as an anastomosis. And anastomosis provides what's referred to as collateral circulation. And I'm going to just abbreviate that because you don't have to have an anastomosis. So collateral circulation, so let's just say that this area here I had a narrowing of this vessel. And this tissue needed more oxygen. And it was chronic. In other words, I wasn't dying, nothing bad was happening, but it was enough of a decrease in blood flow that a term called angiogenesis began. Angio means vessel, genesis means the formation of or the beginning of. So I formed new blood vessels. And it increases extra blood to that area. That's what's referred to as collateral circulation. This is the reason why some individuals can have a heart attack, can have a myocardial infarction, and live, and another individual can have the exact same myocardial infarction and die. Because there are some people that have a greater amount of collateral circulation. Think of it this way. I want to go to Valley River, and Beltline is blocked off. Can I still get to Valley River? Yeah, because there's more than one way to get to Valley River. That's what collateral circulation is. It's one of the things that happens with endurance exercise. Is you build up more collateral circulation, so those are individuals that have a tendency to survive the same type of injury that other people don't. Any questions on the yes, ma'am?
I like cardiovascular training.
Cardiovascular what?
Like cardiovascular training.
Uh-huh.
So do people have more blood vessels in their heart when they're...
It's one of the responses to it. It's genetically influenced, so it just depends. There are some people who they're probably one of the more famous runners of all time was a guy named Jim Fix. He really kind of was bringing running to the environment. He dropped dead, and people are like, see, running killed him. That's why you shouldn't exercise. There's a theory that you're only given so many heartbeats a minute, or in your lifetime. And so if you go running, that speeds them up, and it's actually okay. So if you're really following the logic, when you have cardiovascular endurance, your resting heart rate comes way down. And that's where your heart rate is for the rest of the, let's say you run for an hour, for the rest of the 23 hours in the day. So really, it's better for you. He didn't die. He died, I believe, because he had an aneurysm. Totally different problem. But yeah, that's one of the theories that you're going to end up with better collateral circulation. Now, the one thing we haven't talked about, because we usually introduce it in the vascular system, is blood coming through an artery, it goes to the tissues, and it goes to the smallest blood vessels around called capillaries. They're called exchange vessels, and again, we'll spend time with this in the vascular system. They're exchange vessels because I'm going to drop off my oxygen. I'm going to pick up my wastes, and I'm going to move on. So the analogy I always use to describe this is if you think of each of you as being tissue cells, okay? And basically in between the desks and in between each of you are capillaries. So if I'm a flight attendant and I'm going to give you your peanuts, do I just stand up here and throw peanuts at you? Or do I walk a little closer? Here's your peanuts, here's your peanuts, here's your peanuts. Here's your drink, here's your drink, here's your drink. Not a full drink, because they don't trust you with that, so you only get one small thing, and then you open up the whole can. Now, at some point, when you go through and you drink everything and you eat everything, what are you left with? Garbage. So do I want to have you just, I'm going to stand up here with the bag and throw the garbage at? No. The blood's going to come through, the flight attendant's going to come through, and they're going to do that. And I'm now closer to the thing. That's what capillaries do. That's exchange vessels. So once I've delivered the oxygen to the tissues, it's now going to come back through and be picked up by the veins. Okay? So we have a venous system. And that's one of the things we're going to be going over today from the systemic circulation, but here we're talking about the coronary circulation. Now, again, what you should notice is dark blue, light blue. Dark blue is on the anterior surface, light blue is on the posterior surface. And you've got some important veins here, okay? What I really want you to know about this system is the fact that it all drains into what's referred to as the coronary sinus, which is back here. So all blood from the surface of the heart, not the blood, not the chambers, is then going to get drained into that structure there, the coronary sinus. The coronary sinus, if you go back to when we talked about the structure of the right atrium, is right here. So the coronary sinus just drops blood right back into the right atrium. So all blood coming from the muscles of the heart will enter into that spot. Now, when we have these things occur, ischemia, injury, I'm not delivering to the tissue what the tissue needs. We talk about it from a cardiac standpoint. Some people will feel a pain in their chest. That pain is referred to as an angina pectoris. Okay? A choking of the chest is what it's referred to. Now, some people have it when they get up and walk around. As soon as they sit down, they start taking the stress off the heart, their angina goes away. Some people have it when they're just sitting there doing nothing. That's a bad sign because it means that we have more of an occlusion. Okay? And then if it continues on again, we move through this triad here. Ischemia, injury, death. And again, once you have tissue death, it does not go back. No, angina is the pain that one feels. You have a decrease in blood flow to the area. So the ischemia and the injury is what's causing the pain. And there are EKG signs that show up for most patients when we start having these two things occur. It's one of the reasons why it's important to get to the doctor and evaluate what the signs are. Yes, sir.
Same thing as like, I mean, I know it's not the same thing, but it would be the equivalent of like a TIA.
Yeah. The American Heart Association, really, for those of us who do a lot of teaching for the American Heart Association, they want it taught exactly that stroke is a heart attack. TIA would be the same as having these things. We're just decreasing that blood flow. And then there are different ways that you can take care of it depending on the severity. Sometimes we use those clot busters that I talked about. So that's the reason why we want to make sure we get an EKG, because there is a you don't have to write this down, but it's referred to as an ST elevation myocardial infarction. Those are the ones that respond to fibrinolytics. Other ones don't. So I can give this patient fibrinolytic and see if I can decrease that clot and increase the amount of blood going to the area. The other thing we can do is we can go in and through the femoral vascular system, you move up and you can actually thread this. Let's say the clot was right here. You can bring this down and you can use a balloon. So it goes through and then you scissor it. So the balloon goes up and it increases the diameter of the blood vessel. But then sometimes it closes right back up. We can put in a stent where it goes in and it's like a mesh cage that goes in and it stays there for a while. And then we also have one where you can kind of roto-rooter it out. And the other one is, you know what, they're not a good candidate for any of those. So what I'm going to do is I'm going to take a vessel from some other part of the body, usually the great saphenous vein or a vein in the leg, and you bypass the area that's blocked. They go into the OR and they have this done, they go on bypass. The other thing that they do is they will take an artery instead of the vein from the leg. So they'll take an artery from your hand. So you have the radial artery and the ulnar artery. You just want to make sure that the blood, so if I'm going to take the ulnar artery, I want to make sure the radial artery fills the hand. Because if something happens to the radial artery, then this hand doesn't get blood, and if the hand doesn't get blood, the tissue's going to die. You can actually evaluate it. So if you take your hand and make a fist, tightly you're squeezing all the blood out of it. And if you take your other two fingers and you put it over the ulnar artery and over the radial artery, and then you open your hand up, your hand should stay white. So if I'm evaluating the radial artery, I'm going to take my thumb off of the radial artery, and hopefully my hand will pink back up, which tells me that my radial artery works. So we should be fine taking the ulnar artery from this, and we usually do it from the, obviously, the non-dominant hand, but definitely works. Any questions on that? Yes, ma'am.
I just had a question about the stent. When you put it in, does it just stay in, or what happens after?
Stays in, it's coated with something so that you don't get stuff, platelets attached to it, things like that. But again, they can move, they can, you know, anything you stick in somebody doesn't always stay where it's supposed to be. And if you watch any TV, there's all these class action lawsuits that, you know, has anybody in your family ever had this, and did it result in death? Or what they say is, have you or anybody in your family ever had this, and did it result in injury or death? Well, if it was you and it was death, you're not going to be there to listen to the commercial, so it's so ridiculous. The weird one now, and this is talcum powder and ovarian cancer. I'm trying to figure out what the connection is between someone using talc and ovarian cancer. All right, so any questions about the circulation? Pulmonary circulation, low resistance, taking deoxygenated blood, taking it to the lungs, getting oxygen, bringing it back to the heart. I've got the systemic circulation much, much longer. So because it's longer, it has a higher resistance. That's why the left ventricle is much bigger, taking blood to the rest of the body. And then I have the coronary circulation, which is supplying the heart muscle itself with much, much needed oxygen. Okay. We get into the smaller, the cardiac muscle anatomy. Now remember that this is a little bit different than skeletal muscle. Skeletal muscle is multinucleated. Here, for the most part, it's not multinucleated. If there ever is more than one nucleus, it's just one. So it's either going to have one nucleus or two, but it never has more than that. Skeletal muscle goes the whole entire length of the muscle. This muscle is branched. And it needs to be, because we're going to be playing a game of telephone, so to speak, how muscle or cardiac physiology works. So they're not as long as skeletal muscles. So cardiac muscle, you can see the branching up here and here. they're joined by what are referred to as intercalated discs. And in those intercalated discs contain these things called desmosomes and gap junctions. So, skeletal muscle, we kind of depolarize the muscle fiber, and it goes down the whole muscle. Here, it's like playing a game of telephone. I'm going to come over here, and I'm going to be the cell that starts it. I'm going to say, hey, we need to contract. She's going to tell her. She's going to tell him. And it's going to spread out like that. And how does it spread? It spreads basically by ions moving, and they move through these channels here. And again, it happens in milliseconds. It's not like we get the phone call, start the process, and an hour later we're finally contracting in the back. It's milliseconds. We're contracting. Okay? Because of all of the branching that occurs and through these gap junctions and desmosomes where we have the connections occur. And everything else is roughly the same. There's going to be a slight difference when I talk about the muscle physiology from that standpoint. Now again, because this is going to require a very large amount of energy because the heart never stops, the powerhouse of the cell, the mitochondria, is huge. So 25% of the cell is mitochondria, so that we can manufacture ATP. One of the other interesting things, this is a figure that comes from a different textbook. So remember we talked about this absolute refractory period, that regardless of how big the stimulus is, I'm not going to pass on another stimulus. I won't respond to it. Again, absolute refractory. That's where I was digging the septic tank. And I started, and they said, I'll pay you $1 million to another septic tank. And you're like, no, this sucks. But when you progress farther, you're now in a relative refractory period, and I might require a higher stimulus than what I had before to do it. But you know, I might give you another response. So here in skeletal muscle, you see there's my action potential. One, it's much shorter than the action potential in cardiac muscle. And second, we have a relative refractory period, or an absolute refractory period, and you can see that, again, it's also short. In cardiac muscle, much, much longer. Why would it be necessary to have a much longer absolute refractory period in cardiac muscle?
Allow the heart to go one.
Potentially. That's one of them.
Keep the heart going?
The rhythm is partly, but what?
Keep the heart going?
Why keep the heart going?
Because if it doesn't go, it's possible it stops.
Well, if it does stop, you'd be dead. That's true. If I have an absolute, if I'm violating the muscles in my quads, okay, in other words, I'm constantly trying to send impulses down there. My muscle is going to do what? It's going to seize up. I'm going to get a cramp. Okay? Same thing would happen in the heart, except we have a long absolute refractory period. So the heart can't seize up. It can't get a cramp. You don't get a Charlie horse in your heart. Why? Because of the long absolute refractory period. Now, when we talk about heart muscle and compare it to skeletal muscle, remember that depending on what I'm doing with my legs or with any muscle, I'm going to recruit a certain amount of muscle. So if I'm just walking, okay, my quads and my hamstrings and my glutes are only going to do a certain amount of work. If I go into a full squat, they're going to have to work more, which means I'm going to have to recruit more of the skeletal muscle. Okay? The heart doesn't do that. The heart's like being pregnant. You're never just a little bit pregnant. You might not be showing, but you're still pregnant. Okay? When the heart contracts, it's called an all or none phenomenon. It's like an action potential. If I'm going to have an action potential, we're going to have an action potential. So when the heart contracts, it contracts as a unit. It's not just like you know, I'm just laying in bed. Why doesn't the left ventricle contract? And I'm just going to sit here and do nothing. Okay? The whole thing contracts. Now, I can change the force of contraction. We'll talk about that when we get into cardiac physiology a little bit more. But here, we don't do that. We're just talking about the fact that when the heart contracts, it contracts as a unit. It's called a functional sensation. Okay? And I don't know if that'll ever come up on the test. I would probably tell you what a functional sensation is. But it basically means that it's working as one unit. The whole heart contracts. Now, the heart also has, because of a type of cell that's present there, it's about 1% of cardiac cells. They have this thing called automaticity. Autorhythmicity is the same thing. What that means is if I was to take someone's heart out of their chest and I put it in an appropriate solution, it would continue to beat all by itself because these cells will allow that. Actually, I was trying to find a video of that to show you the depravity that's on the internet, because there's a site, and it was, it's a site that has the word gore in it, and I'm not going to, if you want to Google it, it's up to you. But it was essentially this traumatic car accident. It was a bicycle or a motorcycle, and he was essentially almost decapitated. His chest was ripped open, and his heart was removed from the chest, and it was over here. And it shows you also where our society is. Someone's just sitting there doing this, just videotaping this heart beating outside the chest. And it was a horrific accident. And I didn't want to show it, so if you want to see it, you can Google it. But that's what automaticity is, or autorhythmicity. Okay? Because again, there's a percentage of cardiac muscle, when we talk about it, that has it's about 1%, and they're called contractile cells. Or not, excuse me, they're not contractile cells, they're pacemaker cells, pardon me. Contractile cells are the other 99% of the cells. Now, those other 99% of the cells, occasionally, because of hypoxia, because of drugs, because of ions, electrolytes that are not, they can get a little pissy and they can fire early. But for the most part, it's these 1%, these pacemaker cells. And they're the ones that just fire. They just fire. They tell everything else to follow through from that standpoint. They're the ones who start that telephone game. The ones that come over here and say, we're going to get Jack, pass it on. And they tell everybody, okay? Now, yes, sir.
Do those pacemaker cells, the automaticity, do they have different innervation that allow them to start it?
Yes. So when I say that, like, I can remove the heart from the body and put it in solution, I can also change how fast it beats. I can speed it up and slow it down, and it's because it has innervation of both the sympathetic nervous system and the parasympathetic nervous system, but not every one of them.
Okay.
So these things exist at what are referred to as nodes. So those of you who might have a little cardiac background might have heard of the sinoatrial node, the atrioventricular node, the bundle of His, the right and left bundle branches, and then the Purkinje fibers. Those are all examples that have an increased amount of pacemaker cells. Okay, and when we get a little bit more in depth. So I will tell you that this is where some students, their eyes start to glaze over. So I'm just going to quickly introduce this and then take a break, come back, and then we'll do the vessels, the vasculature. So here, this is an action potential. You should recognize this. Now this is a slightly different action potential because you are not used to seeing this plateau up here where it says number 2. Okay? Now, this is an action potential for contractile cells, the cells that actually squeeze down. Okay? This is a action potential for the pacemaker cells, the ones that have automaticity. In other words, how is it that a cell can just go fire, 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 fire? It's because they have an unstable baseline. Okay, so you don't have to write anything down. Just want to introduce these things to you, and then we'll start this on Monday. But it's just for those of you who want to kind of get a jump on some of this stuff, because again, this is where it gets a little nasty. So we still have the same sarcoplasmic reticulum. We still have the same actin and myosin. That hasn't changed like any muscle. And our action potential is essentially the same. Now, this is contractile muscles. This is the 99% of all cells. So Sodium is going to come in. This is our depolarization. That should not be news to anybody here. Okay? What should be different is the fact, again, that we see this plateau that's occurring here. The plateau occurs because, one, we have our potassium gates that are opening, but they're very slow to open. Normally, we would just see this drop for our repolarization. But our calcium gates open here, and these are called slow calcium channels. All right? Not slow because of the rate at which stuff comes in, slow because of how quick they respond. So that's what's causing that plateau, why I'm not going immediately into a repolarization. Now, the important thing here is the fact that about 10–20% of calcium is going to leak in, and it's going to actually cause the calcium from the sarcoplasmic reticulum to be released. It's called calcium-reduced calcium release. And then we have contractions. And then they're going to close, and our potassium is going to open, and we have repolarization from that standpoint. Okay? So sodium coming in, calcium coming in, potassium going out. That's the way I'd write it in your book, so that you know what's occurring at those two phases. And then if you notice, the darker blue is my absolute refractory period, and this is the tension that's being formed by that contraction. Now this is what happens in our pacemaker cells, that 1% of cells. So at 1, what's occurring is we have these leaky sodium channels. Not a sodium channel that's fully open. The leaky sodium channels. So sodium is going to come in. But what also happens here is our potassium channels close completely. Because remember, what direction would potassium go if they were open? Out. And that would hyperpolarize the cell. Here my potassium closes so they can't go out. Sodium leaks in, I reach threshold, and then we have fast calcium channels. That's what's happening here, not slow calcium channels. And this is what's telling the cells to do this. And then our calcium channels close, potassium channels open, and the whole thing starts again. They're based off of voltage. And so that's why I can sit there and it's like, okay, I'm going to fire. So I reach threshold because they're leaking, and then my calcium opens up, and when calcium gets to a certain point, they've shut down. And then potassium opens up. And then when potassium gets to a certain point, it closes down, and that sodium's allowed to leak back in. That's how it's a pacemaker cell. It doesn't require anything, just the appropriate solution. Glucose, oxygen, that type of thing. Okay? So we'll start off talking about that exact slide on Monday. So I'm going to take about a 5-minute break, come back, we'll go ahead and tackle the vascular, the blood vessels that you need to know, and we'll go from there. So blood vessel, okay? Again, this is going to be the thing that makes up 10 to 12 points of the next exams. And you're going to be given a question that's like, going on a trip. I'm going to start you in a particular part of the body, and I'm going to tell you what your first vein is in, because that's how this blood flow process is going to work. And then you are going to take yourself all the way back. Keep in mind, the one thing I do expect you to know, and I probably should have prefaced this yesterday, the one thing, at least by tomorrow or Saturday, you should know is you should be able to walk yourself through the blood flow through the heart. Okay, so you should be able to say blood's coming into the inferior superior vena cava, into the right atrium, goes from the right atrium down to the right ventricle to the pulmonary trunk to pulmonary arteries, lungs, pulmonary veins, left atrium, left ventricle, aorta. That's one thing that you should be able to do. You should also be able to tell me what the names of the valves are in between. Okay. Now, in the blood flow question, I do not anticipate that you have to tell me that I'm going through the tricuspid valve. You can say that I'm going from the right atrium into the right ventricle into the pulmonary artery, lungs, and say it just like that. And as I stated the other day, you have to either write artery or the Leo period, or you have invariably I have somebody who asks me, like on the day of the exam, do we have to write B? Yeah, you have to write A and B. You also have to write R and L, or right and left, if there's more than one vessel. Okay? You will get points off for that as well. Even if you're talking about, I'm in the left subclavian, left axillary, left brachial, and you write radial, and then you write left palmar arch, and you're like, well, duh, it had to be an L because the one before. No, you have to write left and right. Okay? Just being forewarned is being forearmed. Now, when you look in your textbook, okay, you're going to see a couple different diagrams. You're going to see one like this that looks more like a piping system. The body's been removed, and some people get this better than this structure here. Some people like the structure because it's got the body there and it kind of puts things more in perspective. It's totally up to you. Okay? I don't really care. Now, when we start this process, we're going to start with the arterial side. And the arterial side is one that branches. So when you read through the textbook of the veins are going to talk about things joining because blood's coming back. So here we're going from big blood vessels to smaller blood vessels, whereas in the venous system you're going from smaller blood vessels to bigger blood vessels until you get back to the body. So, and you're going to see some of these, by the way, on multiple slides because I'm going to be showing things from different views. Now, I just want to show you a picture so you can kind of get an idea. The aorta is where we're going to start. Okay? And the aorta has three parts to it. It has an ascending aorta, it has an arch of the aorta, and it has a descending aorta. Okay? The descending aorta is then divided into a thoracic aorta and abdominal aorta. What makes that distinction is the diaphragm. If I'm above the diaphragm, it's a thoracic aorta. If I'm below the diaphragm, it's a abdominal aorta. Now, the ascending aorta, very small. It's about a little over an inch. Okay? We have the sternal angle, structure in our sternum, that the angle of Louis, which is right here, that's essentially where the arch takes place. That's also where, by the way, it ends. It's an arch, right? So arches do what? They go up and come down. So it goes up and comes down. Beginning of the arch, into the arch. Then the descending occurs. Now, that's not going to show up on the exam. Just trying to point out a couple things to help you remember stuff. It looks like a candy cane, does it not? Okay, so the arch is the top part. Top part of the candy cane. Three things come off of it. Okay? The first one is the brachiocephalic artery. Notice I did not say the left brachiocephalic artery or right because there's only one of them. So it's called the brachiocephalic artery. The middle one is the left common carotid artery. And then the third is the left subclavian artery. Now again, I'm going to come back to the slide. I just wanted to kind of give you an idea because we're going to look at the right side first. So here is the arch right here. And what we're looking at is the first branch, okay, which is my brachiocephalic artery. Now it has branches to it. One of the branches from the brachiocephalic artery is the right common carotid artery. Now notice, now I have a right, because I also have a left common carotid artery. Some of these I'm only going to show you if they're identical on both sides. So when I go through this, I'm going to go through the vessels on the right side of my arm. I don't go through the vessels on the left side of my arm. Why? They're exactly the same. I'm pointing out some of the differences, and the brachiocephalic artery is one of them. And then what happens is as soon as we kind of make this turn and we start moving towards this first rib, it becomes the right subclavian artery. This is kind of like driving on Centennial and turning into Martin Luther King. Did you get off the road? No, I just changed the name. If I'm coming in through Bend and I'm going to the coast, I'm on 126. When I get into Eugene, what street am I on? West 11th. West 11th then turns back into 126. Unless you're somebody who's about 80 and always drives with their hat on, and then they're on 126 all the time. Like, well, where can I go find a burrito boy? Oh, it's on 126. Where the hell is 126? What do we call it? West 11th. You're on So the right common carotid artery is then going to divide. It's going to bifurcate. It's going to become a right external carotid artery and a right internal carotid artery. Now, once you get this down and you start reading through the textbook, you can send me your thank yous later, because I'm not going to require you to know what's called the circle of Willis, which is the blood flow to the brain. Okay? What I do want you to know is that the right internal carotid artery increases blood flow, or sends most of its blood to the brain, whereas the external carotid artery feeds the face and the tongue. It's one of the reasons that we use a vasoconstrictor during cardiac arrests, because when you're doing CPR without it, a lot of the blood tends to favor going towards the external carotid artery. So the brain dies, but the tongue lives forever, is one of the phrases. So when we give them a vasoconstrictor like epinephrine, it shunts the blood more towards the internal carotid, increasing the amount of blood flow to the brain. So we look at this picture, again, you're going to see some of the same structures, just from a different view. Here's my brachiocephalic right there, artery. This is my right common carotid artery. Now we're going to move down to the arm. So there's my right subclavian artery, and as I keep going, as I get near my armpit, it's going to become my right axillary artery. It's then going to continue down, and you don't have to worry about the deep brachial, it's not that important. That's why it's not labeled. So you're going to come down, and it's going to turn into the right brachial artery. So those of you who take blood pressures manually, this is generally where your stethoscope is going to be, which is right in this area here. You're listening for blood coming back into the brachial artery as you change the, or release the pressure on the blood pressure cuff. The brachial artery is then going to divide, and it's going to have the right radial artery, which is going to be on the thumb side, where the radius is. So again, remember your bones from AMP1, makes it pretty easy. And then we have the right radial or right ulnar artery, which is on the other side. Much more difficult to palpate. So that's why when we take pulses, we generally feel for the radial artery, because it's much easier to palpate. Now they come up in form what's referred to as the right palmar arch. Now this is the one, rare one, you really don't have the right artery on. And a little leg. Okay? And it's just by convention, they generally don't. You can find it in some, it's not everyone. But it's just the ones that basically feed the hand. That was the whole thing about me pushing my hand down, squeezing the blood out, including both artery, both radial and ulnar, lifting it up. And then again, if I wanted to check how well the ulnar artery worked, I would release it and see if my thumb or my hand pinks back up. The left is exactly like this. Okay? Now, I'm going to show you the only major difference on the left. Remember I said we had a candy cane at the top of the arch, and there were three things that came off of it. The first one was our brachiocephalic, which was right there. Here we have our left common carotid, so it doesn't come off of brachiocephalic, it comes off of the arch of the aorta. And then the third one is the subclavian, the left subclavian artery. And at that particular point, it's exactly like the right. The left subclavian artery goes to the left axillary artery goes to the left brachial artery divides and goes into the left radial artery, left ulnar artery, and then it goes to the palmar arch, the left palmar arch. Okay? Now, are there more blood vessels than that? Yep. You don't need to know them. These are the kind of the big ones. Okay? Now, we're going to kind of continue down. So I'm going to move through, and we're going to go through the descending. Now remember, the descending has branches to it. So we have an ascending, which is again about 1.5 inches. We have our arch, starts around that angle of Louis, ends at the angle of Louis. And then we have descending. Remember, the descending has segments. If I am below about T12, then this is a thoracic aorta. And if you, this is one of those ones that it's kind of like there were some bones where you didn't have to write the word bone after it, depending on the word that you use. If you use the term aorta, you generally don't say artery. If you use the term aortic, you use the word artery. It's just one of those convention things, and it's a pain in the butt. But so if I would say this is a thoracic aortic artery, I could also just say it's the thoracic aorta. Okay, potato. I'd pick one. If you were smart, you might want to pick one that requires you to write artery, because then you know I'm going to write artery or vein on everything. Okay. And then this would be the abdominal. Now, as we go into the abdominal aorta, we have our first branch. Now, this is going to be a little tricky because it's not 3D. So if I was to then take this, if this was my abdominal aorta, if you think about it, a person laying flat, you have a thing called the celiac trunk that comes up. So it looked like that. It comes out. And then there's going to be branches off of there. My fingers would be the branches. Okay? So this structure right here is the celiac trunk. And there's branches from that. We're going to have, and when you read through your book, it's going to be slightly different. I'm going to explain why. We have, this is actually called the left gastric artery. I just want you to notice the gastric artery. Okay? It goes to the stomach. Okay? Now there is a right gastric artery that comes off of the common hepatic, and it forms the lesser curvature of the stomach. And it's just not that important. So that's why I just want you to know the gastric artery goes to the stomach. And then I also have the splenic artery. The splenic artery is going to go to the stomach, the pancreas, and the spleen. So it's this one that kind of winds there. Notice how there's no right or left, because there is no right splenic artery and there's no left splenic artery. It's just a splenic artery. Now, again, we're talking about, since I laid it flat, we're talking about the trunk. So on the celiac trunk, one branch goes off and forms my gastric and my splenic. The other one forms one that's called the common hepatic artery. Okay? And so it's this branch right here. Now, it's going to continue on, and it's going to go to the liver. And it's going to be referred to as the hepatic artery proper. Now, in some textbooks, you're not going to see the word proper. What they're trying to do is to make a distinction that the common hepatic artery is not the one that goes to the liver. I mean, in a way it does. It's like being on 126 West 11th, 126. Okay? It's just that's not its name when it gets to the liver. Its name is the hepatic artery. And to make the distinction between the hepatic artery and common hepatic artery, a lot of anatomists will put in the term proper. I don't really care as long as you know for a fact that hepatic artery is different than the common hepatic artery. So you should, in your head or in your notes, make a point to say the common hepatic artery, I'm going to get there first before I get to the hepatic artery. Now there's another artery on here, and I'm going to show it to you twice because this one is actually hidden away by organs that are present there. But it's referred to as the superior mesenteric artery, and you see it right here. So I would pull, I'll show you a picture in just a second where I'm going to pull this away, and you're going to see that the superior mesenteric basically originates inferior to the celiac trunk. So here is the organs being removed. My celiac trunk is right there. And right here is my superior mesenteric artery. And it essentially goes to most of your intestines. All of your small intestine and most of your large intestine. Just slightly underneath the superior mesenteric, we have our renal arteries. So these are our kidneys. Okay? So obviously, since I have two kidneys, I have a right renal artery and a left renal artery. Now the book's going to spend a little time telling you that the right renal artery tends to be a little bit longer than the left, primarily because the inferior vena cava is right there. And as I move down even farther, still on that. Descending the abdominal aorta, we have the inferior mesenteric artery. This goes to the lower parts of your large intestine, like your rectum. So between the superior and inferior, pretty much encompasses all blood flow to that area. Now, somewhere around L4, L5, again, not going to ding you on the location, just want to let you know that there is an idea about where these things are going to stop. That aorta is going to terminate. It's going to split. Okay? And when it splits, it's going to form the right common iliac artery. It's also going to form the left common iliac artery. These are going to be structures that are going to essentially feed your genitals, the muscles of the pelvic floor, so things that help feed the muscles that help to regulate bowel movement, things like that, and then obviously your limbs. Okay? Now, as we look at the right side, this right common iliac artery is then going to divide. And it's going to form right here as it goes underneath. It's going to form this right external iliac artery. Now, when you read through your notes or read through your textbook, there is a right internal iliac artery that you do not have to know. Those are the ones that essentially go to the genitalia, the muscles of the pelvic floor. Okay? The right external, as it comes underneath the inguinal ligament, will form the right femoral artery. So if you've ever been involved in a cardiac resuscitation, it's not uncommon, we see it more in hospital than pre-hospital, for somebody to kind of have their hand on the person's groin, because what they're feeling is, do I have blood flow going round and round? Do I feel a pulse in my femoral artery? Okay, because it's one of the biggest ones, and it's fairly easily to access during a cardiac arrest. So that femoral artery is then going to start down, and this is what's going to essentially feed most of the muscles of the anterior thigh. So the one thing about it is that as it starts to get, so it's on the medial side, as it starts to get more distal, it goes posterior. And there's this structure called the adductor hiatus. And once it passes through the adductor hiatus, it's now posterior. And at that particular point, it becomes the popliteal. So see how it gets lighter, which means it's posterior? So that's the popliteal artery, the right popliteal artery. Okay? See it right here. So this is the posterior. So femoral comes down, goes to the adductor hiatus, and becomes the right popliteal artery. By the way, most of these are areas that you should be able to palpate, with the exception of the ones that are deep. So the abdominal ones we don't palpate. But this is one you can definitely put your hand behind your leg, and you'd be able to feel pulse there. Okay? Now, that popliteal, I'm going to have part of it is going to come anterior, and it's going to form that right anterior tibial artery. So that's the one that you see right here. And then the one that continues down is called the right posterior. So that's the one that, if you feel for your medial malleolus, your ankle bone on the inside, right posterior to it, you should feel a pulse. That pulse is your posterior tibs. Again, this is one of the things, well, let me go over the last one and then I'll make the statement. That posterior tib and the anterior, as it comes down, they help to form the structure on the surface of your foot called the right dorsalis pedis artery. So that's, well, again, if you watch a physician, specifically a patient who's had vascular surgery, it's not uncommon. You almost think that the physician has a foot fetish, because they're going to come in, they're going to be talking to the nurse to get report. Their hands are just basically going to be on the anterior surface of the person's foot, and they're going to be feeling for the dorsalis pedis, and then they're going to rotate their hands inward so that they can feel the posterior tib, which is right there, so that they know that there's good circulation to the leg. That technical. They also are feeling the temperature at the same time, because if you have cold feet, more than likely you might have cold. So this is the arterial side. most part, it's going to be pretty straightforward because they have some of the same names. There are a couple distinctions, and again, these are distinctions that you should be making in your notes. So again, you can have this diagram here that's more of a piping system, or you can have the one that's actually superimposed on the body itself. Okay? So when we start this process, everything again is going to be coming back. So I'm going to talk about the same way I do the arteries. I will kind of say this joint's here and this joint's here, but it's a little harder to do because I have to start the lecture kind of in reverse. But superior vena cava is going to essentially drain most everything again, chest, head, that's it. Your book says everything above the diaphragm. There's a couple other kind of controversies about that, but it's not necessarily incorrect. Now, what drains into the superior vena cava? My brachiocephalic vein. Now, what do you notice about this brachiocephalic vein? The word. What's in front of it? Which means there is a left. That's a big thing you should write in your notes, because in the arterial side there is only one brachiocephalic artery. Here you have two brachiocephalic veins, a right and a left. They basically form the superior vena cava. Where the two brachiocephalic veins come together, now it becomes the superior vena cava. So when we look from this particular shot, we've got my right internal jugular vein, fairly large one right here. Okay? Slightly distal to that, we have our right external jugular vein. Now, veins are things that we have a tendency to cannulate. In other words, we put tubes in. So I can put some tubes in arteries. The name's completely different, bless you. But here, we generally name the vessel where the cannula is. So when you give a report, you say the patient has, an 18 gauge in the right EJ. Again, very lazy. So it's this one here. This is the one that when you start IVs, or when you begin to start IVs, you really like, because it's this throbbing one. That's not throbbing, it's a vein, but it's usually one that's fairly large on the outside. Okay? So certain nurses, ER nurses, are generally allowed to access the external jugular. Internal, usually this is left perfusion. This is a very difficult process to put an IV in. Same with subclavian. Now, similar to the artery, the right internal jugular vein drains blood from the brain. The right external drains blood from the face. So far, that's one of the differences between the arteries and the veins is the name. But here's one that should look familiar. Here's the right subclavian vein. When the right subclavian vein and the right internal jugular come together, that's what forms the right brachiocephalic vein. Here's kind of a front shot, just like we did on the last one, where we have the structures that are present there. But here you can see the left brachiocephalic and the right brachiocephalic, and this is what's forming the superior vena cava. Okay? And everything is identical in the venous system on both sides. So we have the left internal jugular vein, the right internal jugular vein. We have the left external jugular vein, we have the right external jugular vein. We have the left subclavian vein and the right subclavian vein. So that's the reason why you don't see the left over here, because the left looks exactly like this. And again, there will be some differences when you get, whether you start doing phlebotomy, where you're drawing blood, or where you're actually sticking IVs in and leaving them in, you'll get fairly good about noticing where certain veins are on people. So there always will be some differences between individuals. Okay? So, up here, when we draw blood from a phlebotomy standpoint, some people kind of have an H shape and some people have an M shape as far as their veins go. So